make sure you guys can see my slides and hear me.
Yes, we do.
Great. A lot of these topics, fortunately, have been, or unfortunately, I should say, whichever way you see it, I would say, fortunately, have been touched on by some great lectures before. So I'll brief some of them, but I kind of want to try to take the time to merge the world of deformity and the world of tumor if possible. So in terms of learning objectives, I just want to everybody to kind of learn it or get a basic understanding of the spinal deformities that are associated with this neoplastic conditions, and to identify some common treatment strategies that we use for reducing these deformities when it comes to neoplastic conditions. No true disclosures. And so spinal deformities and neoplastic conditions, the majority of them are kyphotic in nature. Like Dr. Shua was saying in his lecture before, a lot of them are secondary to collapse of the anterior body. They're mostly due to failure of the anterior middle column. There is an exception to this in the upper cervical spine where translation or rotational deformities may occur, but the vast majority of deformities that we encounter in our field when it comes to neoplastic condition will be kyphotic. When the neoplastic conditions do start involving unilateral or bilateral pedicles, as well as the chest wall, you can start having a coronal deformity as well. Anterolacesis and posterolacesis might occur as well, but usually it's rare because it has to involve bilateral or at least a singular facet. And like we heard before, this is not a very common condition. A very important rule when it comes to these deformities is that they're very flexible, unlike many of the adult deformities that we encounter. So they're more paragraph, more similar to the pediatric conditions, and that they might be more reducible with less aggressive maneuvers. This is just a brief view of some of the kyphotic common deformities that we encounter. On the left, the T4 vertebral body collapse with a kyphotic deformity with about a 25-degree Kolb angle in focal kyphosis. And then on the right, we have a C5 vertebral body destruction with reticulocesis and a kyphotic deformity with about a 15-degree Kolb angle. This is a more significant kyphotic deformity, which unfortunately is more rare, with a 90-degree kyphotic deformity in the T5 region. So Dr. Shiva gave an excellent talk on the SINS criteria, so I won't dwell on it, except to mention once again that deformity is part of the criteria. It comes into when you encounter or you're measuring those radiographic spinal alignment, and deformity includes both increased kyphosis, focal kyphosis, coronal deformities, and sagittal deformities. In terms of correction techniques, because these deformities are very flexible, they can be more easily reduced. It's something with more simple maneuvers that I mentioned before. In particular, a combination of positioning, traction, expandable hardware, instrumentation are really our go-to tools when reducing this mostly kyphotic deformities. When it comes to positioning is key. It's key for a lot of the deformity conditions that most people in this audience know today. Appropriately positioning can really decrease a Kolb angle. And in some of the literature, they actually found that it decreases between 6 to 14 or 15 degrees just from positioning alone. At our institution, we favor using a Jackson table for the thoracolumbar metastatic lesions. And when it comes to cervical lesions, we either use the Jackson table or regular table with a MA field head attachment. Cervical traction is also an adjuvant tool that we can use for the reduction of this kyphotic deformity, particularly when it comes to the cervical spine. That can be very useful in reducing translational and rotational deformities from C1, C2, or condyle involvement of these metastatic lesions. Of course, as everybody knows in this audience, I'm sure, care has to be taken when applying the weights. And, if the patient is not awake, using neuromonitoring is always encouraged. A lot of these, because they're very flexible, they can be easily over-distracted. So care must be taken when putting too many weights into the reduction field. We had some great demonstrations in the lab today when it came to expandable cages, but they really are very powerful when it comes to reducing kyphotic deformities, and particularly metastatic disease. Placement either anterior, lateral, posterior, lateral, it really varies, and without any favorite one of them, they really can provide a significant expansion and significant reduction of these deformities. Now with advancements in these cages with modeled pieces and adjustments to the end plate attachments, even more of a normal alignment can be introduced as these cages are being deployed. There's many papers on replacement and a reduction of expandable technology, and overall they found between 5 to 27 degrees of reduction of kyphosis when using these cages, and even in cases where case series where they include tumors, they found up to 93% fusion rate, which is very, very good. Pedicle screws and hooks and rods are bread and butter, and they really are one of our armamentarium, one of the basic tools. They really come in pretty handy when it comes to reducing these kyphotic deformities in the cervical, thoracic, and lumbar spine from neoplastic disease. Cantilever techniques as well as incital bending can really provide adequate reduction and restoration of global alignment. The use of osteotomies, either facet or complete facet, Smith-Peterson's or vertebral column resections, is really rare for these tumors because they're so mobile, and a lot of the work is really done for you by the tumor destruction. It's good to have them in your armamentarium when it comes to reducing these some of these severe kyphotic deformities if necessary. But in reality, the work has been done by the neoplasm itself. One of the key points I do want to make is to merge the world of spinal deformity with the world of neoplastic and management of neoplastic disease. As we understand more the alignment goals and spinal pelvic parameters, having at least a basic knowledge of these parameters and employing them when using your surgical planning can be really helpful, especially in the long-term the patient outcomes of the patients that we're treating. With all these adjuvant therapies and improvements in the therapies overall, with patients having a longer life expectancy, patients that are overall in misalignment, they might present at later stages with either hardware failure or progressive kyphosis or progressive deformity, proximal junction kyphosis, for example, at the proximal or distal segments. In general, the knowledge of the C2, C7 SVA, the T1 slope and the tilt, and cranial tilt and so forth, as well, of course, the now very validated and very useful lumbar lordosis, kyphosis, pelvic instance parameters and their relationship overall. Applying this to our understanding of metastatic disease and when we apply our correction, it can lead to a better functional outcome and patient satisfaction in the long term. I won't touch too much about the T-Robust and kyphoplasty. We had an excellent talk about it, but there is a lot of talk about the reduction of kyphosis with kyphoplasties in particular. Numerous papers are out there on case series with a reported rate of 2 to 5 degree improvement in overall kyphosis with segmental augmentation. Particular, some of the lectures mentioned before, they also can assist in the prevention of further kyphotic deformities, and as we just had in our lab demonstration a couple minutes ago. I'll touch on some brief cases real quick, and then move on. So this is two cases we had recently in our institution. This is a 57-year-old female with a new diagnosis of small cell lung cancer, non-small cell, I should say, who presented with worsening mechanical backbone imbalance. Bones have been examined with an ataxic gait and its re-extension below lower extremities. Our MRI showed a T4 destructive lesion with focal kyphosis with about a 25-degree Kolb angle, with impingement on the cord and severe stenosis. In this particular case, we actually decompressed, and we actually employed using methacrylate. We first reduced with the use of the positional, like I mentioned before, and the instrumentation in the form of the screws and rods. And after we had obtained what we consider good alignment, then we filled the defect with cement, and then we compress it to keep it in place. In a second quick case I'll mention is a 63-year-old male with unknown primary who presented with worsening neck pain. He initially had been watched, but then it started having more pain with movement, flexion, and rotation. Initially was noted to have a C1 lesion with a moderate uptake on PET scan, which was being monitored and was being worked up for IR biopsy. He actually showed with progressive pain with noted destruction of the C1 and some rotational component of instability. And in this case, we reduced them with their traction as well as the Mayfield pins, and we locked them in with an LC fusion. So really like three take-home points, as Dr. Shaman mentioned before. This is kind of like an evolving field, but it is interesting to merge these two worlds of spinal deformity and oncology, in particular with when it comes to taking into account global spinal pelvic parameters. like I mentioned, a lot of deformities are metastatic and kyphotic in nature. They're very flexible. They respond very well to reduction maneuvers such as positional instrumentation. But using these spinal pelvic parameters especially when considering long-term goals of the patient, can be very useful. And I'm sure it's an evolving field that will heal more over the next couple of years.
Well, thank you for that talk. That was very insightful. And I think one of the things that is really important, and as our patients are surviving longer and longer, you may be able to kind of keep their neurologic status going, but if you put them in a bad position, they may not be all that happy. So, I think this intersection of deformity and tumors surgery is something we're going to have to consider more and more as our treatments get better. So thank you so much.
Brown, thank you for having me.